So where that woman is sitting is the last place I think we can put a chair. But you can say that it's for a little stool right next to it.
Hello again.
Well, I think I get a minute in the opening to do that.
So, I think it's doing he wants his name. But I don't know.
But I thought your guys' point was like, no, he's cramming a good. Waste on him.
I would just note that some of the governors have been here in town for a couple of days. They're anxious to get back to their home states. We know that the airport is only minutes away, but because of that, we're going to be can be right on in terms of the clock. So expect a fast gavel for all of our members. This month marks the one-year anniversary of the President signing into law a pair of controversial health care bills that are transforming the way Americans receive and pay for health care. We convene this hearing today to hear from the governors about what impact the health care law has had on their states thus far and what they believe to be the toughest challenge that they face in implementing the President's health care reform package over the coming years. Medicaid currently covers nearly 54 million Americans, and the administration's chief health actuary has estimated that the Medicaid expansions included in the law could increase the nation's Medicaid rolls by at least 20 million beginning in 2014. While the President's health care reform package altered the relationship that the federal government has had with the states by requiring that states drastically expand their Medicaid populations, governors are also deeply concerned about the new unfunded mandates in the law and their impact on current state budgets. The CBO estimates that these mandates and expansions will cost the states at least $60 billion, but the states themselves estimate the cost to be nearly twice as much. Today, I join members of the Senate Finance Committee to release the first comprehensive analysis of what the states themselves expect to spend as a result of the health care law, and the results are sobering. Even using conservative estimates, the states expect to face an additional $118 billion in costs through 2023 as a result of the law's mandate. Today's governors cannot afford to continue offering the same benefits in the same way to their existing Medicaid populations. However, the health care law puts them between a rock and a hard place. They cannot make eligibility changes in their options programs because the health care law freezes their current programs in place for years. This hearing will be an opportunity to hear from three of the nation's most thoughtful governors. Although as governors you are following very different roadmaps concerning health care reform, I believe that you can all agree that state innovation and flexibility are key, and I yield now 1 minute to Mr. Barton.
We thank you, Mr. Chairman, and I welcome our governors here who right now are empty chairs, but I'm sure they'll be here at the appropriate time. I'm going to put my entire statement in the record, Mr. Chairman. Simply put, this is the same old story, just a new chapter. We have heard year after year that we need more flexibility for our Medicaid partners at the state level. My governor of Texas has sent a letter that I'll put in the record at the appropriate time, and he points out that in Texas alone, Medicaid is going to be 25% of the entire budget, and over the next 10 years, it's going to cost an additional $27 billion in state matches to the federal government. So this is a very good hearing. I look forward to listening to the three governors today and working with all governors of the 50 states to try to find a solution to help maintain this program and continue the benefit package, but also find a way to impact the cost curve. And thank you, Mr. Chairman, for the hearing.
I yield the balance of my time to Dr. Burgess. 2 minutes.
Thank the Chairman, and I thank the governors for being here. I know it is an extra effort on your part. And I do want to thank the Chairman for his commitment to listen to the states in this exercise, because it is so critical what happens at the state level. There are a handful of people on this panel that have actually seen a Medicaid patient in their professional careers before coming to Congress. I'm one of those. So when I point out the massive flaws in the system, it's not out of a lack of compassion, but precisely the opposite. The federal government created this system to care for the poor, the poorest in society, but it's really now become an empty promise, because oftentimes it's a bait and switch. The countercyclical nature of the program encourages growth in times of financial excess, and then you're hit with maintenance of effort when the economy goes bad. Those with Medicaid find themselves unable to access services because Medicaid pays so much less than comparable services. Even Medicare pays better than Medicaid. So Medicaid patients soon realize that coverage does not equal access. During the debate held over the Patient Protection Affordable Care Act, we never tackled the basic question. If we were to start fresh with a blank sheet of paper, what would it look like? Would it look like it does today? And really, very few of us on this side doubt that it would. Time after time, providers cite the low reimbursement, the paperwork as the two most important reasons for limiting their participation. And then we expanded the situation without improving it, so we made it worse. Here's the question: why do we even still have Medicaid in 2014? The answer is some people involved with the genesis of the law signed a year ago didn't care about how to provide the best care or how to coordinate or to get more people to purchase innovative insurance products. They needed to keep a CBO score down, and that meant lumping everyone into Medicaid right at the last minute. Mr. Chairman, I thank you for your indulgence. I'll yield back.
I would recognize the ranking member of the full committee, the distinguished gentleman from California, Mr. Waxman, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. Today we'll hear the views of several of the nation's governors on the impact of the Affordable Care Act and on the nation's critical safety net health program, Medicaid. Medicaid and the ACA are both partnerships between the federal and the state governments. We share the responsibility for making these programs run efficiently and serve the needs of the populations that depend on them. So this can and should be a productive dialogue. But in my view, that does not include relitigating the Affordable Care Act. ACA is already delivering important benefits, prohibiting insurance companies from rescinding insurance when someone gets sick, requiring coverage of preventive care for no cost, allowing young adults to stay on their parents' insurance up to the age of 26. 3 new reports we are releasing today highlight the benefits of the new law in the states represented by the 3 governors who will be testifying. They show, for example, that in Utah, 1.8 million residents are already receiving consumer protections against the worst abuses of the insurance companies. In Mississippi, over 30,000 seniors have already saved hundreds of dollars on high Medicare drug costs. And I'd like to ask, Mr. Chairman, that these reports, which show precisely how much the Affordable Care Act will help millions of Americans, be included in the record.
Without objection.
The Affordable Care Act gives states a major role in its implementation. It allows great flexibility for states to run new health insurance exchanges and to continue to run their Medicaid programs, the subject of today's hearing. At this time, I'd like to submit for the record a February 3rd letter from Secretary Sebelius describing the flexibility that exists in the Medicaid program. And without objection, Mr. Chairman, I
Again,
hope
without objection.
It's no secret that states are having problems with their budgets and that the recession is a significant contributor. When unemployment increases, state revenues decline, and more people rely on Medicaid and CHIP. And Medicaid has been working exactly as intended. Medicaid has enrolled an additional 6 million people during the recession, many who lost other forms of insurance when they lost their jobs. Medicaid is the final safety net for these families, but the program is still extremely efficient. As a matter of fact, Medicaid spending growth on a per-enrollee basis has been slower than increases in private health insurance premiums. What would be helpful here is to make Medicaid a program that automatically corrects for recessions and disasters with additional federal support, so states are not stretched beyond their means at a time of economic stress. When Medicaid enrollment grows to help people losing their jobs or in a crisis. I want to highlight other important facts about the program. Medicaid covers 45 million low-income children and adults. It assists almost 9 million seniors and people with disabilities with Medicare costs. It covers 70% of nursing home residents and 44% of people with HIV/AIDS. It is the nation's safety net program that helps those most severely in need. The program's benefit package responds to the needs of the population it serves, providing prenatal and delivery care, speech and occupational therapy, case management, and community-based care that helps individuals with disabilities stay out of a nursing home. Medicaid offers states considerable flexibility in the management and the design of the program. To be clear, there are aspects of the program we can improve. We can reduce costs for 9 million duly eligible beneficiaries, low-income seniors and disabled that are eligible for both Medicare and Medicaid. This group accounts for just 15% of total enrollment, but 39% of total Medicaid costs. Here's where the ACA helps the states. It establishes the Federal Coordinated Health Care Office to reduce the costs and increase the quality of care for the individuals. It established a Center for Medicare and Medicaid Innovation with a charge to identify and develop policies to improve care and cut costs. These are the changes we need to concentrate on, not radical changes that will add to the number of uninsured. A number of governors have suggested a Medicaid block grant with no standards for coverage or care. This idea was discredited 30 years ago, and it will be discredited again. It will leave states with inadequate funding and remove the federal commitment to be a full partner. It will result in loss of coverage for the most vulnerable and severely disabled adults and children, people needing nursing home care, and poor children and families. And it will exacerbate unfair distributions of dollars among the states. Calls to block, grant, cap, or cut this program under the guise of flexibility and fiscal restraint are short-sighted. I hope we can concentrate today on how we can work together to make our programs run better, not destroy them. Thank you, Mr. Chairman.
Thank you. We now recognize the chairman of the Health Subcommittee for 5 minutes, Mr. Pitts.
Thank you, Mr. Chairman. Right now, states across the nation are struggling to balance their budgets and reduce costs without sacrificing the quality of care for their current Medicaid enrollees. Many states have already made deep cuts trying to achieve balanced budgets. But under the maintenance of effort provisions in Obamacare, if a state takes any action that makes eligibility for Medicaid more restrictive than the standards in effect for the state's program as of March 23, 2010, that state could lose all federal funding. If states can't change their eligibility criteria, governors are left with little flexibility and few choices but to cut payments to providers or cut other parts of the state budget, for instance, education and transportation, in order to maintain federal Medicaid spending. What does this look like for my home state of Pennsylvania? In an op-ed on usatoday.com, Pennsylvania Governor Tom Corbett today wrote, quote, Pennsylvania's Medicaid program, for example, has seen steady, unsustainable increases in the number of people it serves and the cost of those services. The Keystone State's Medicaid budget is growing at nearly 12% a year, while the Commonwealth's general revenues have grown by just 3% a year. It is a trend that simply cannot continue, but one that will be unavoidable as long as inflexible federal rules guide state policies, end quote. A May 2010 Kaiser Family Foundation report found that by 2019, Pennsylvania's Medicaid rolls may grow by an additional 682,880 people and may cost the state an additional $2.04 billion over the 2014-2019 time period. Many of our governors, including Governor Herbert of Utah and Governor Barber of Mississippi, who are with us today, have already spoken out, asked the Secretary of Health and Human Services to relieve them of some of the restrictive health care-related federal mandates, including the maintenance of effort provisions. The responses they have received have not been encouraging. So I look forward to hearing from our witnesses today and learning firsthand what the impact of Obamacare will be on state Medicaid programs, on other state health programs. I'm also interested in hearing their ideas to provide access to quality care for greater numbers of people while keeping cost under control. At this time, I'd like to yield 1 minute to Dr. Ganger of Georgia.
For yielding, new CBO numbers on Obamacare are out in the news is definitely not good. Costs have increased by $460 billion in just 2 years, and state Medicaid costs rose by 300% from $20 billion to $60 billion. Can states reform their programs or do a better job of screening out individuals who don't belong in the program in order to deal with these crushing costs? No, they can't. Obamacare expressly forbids them from making eligibility changes that might remove people who are illegally in the program until at least 2014. Well, can states afford to wait until 2014? Rhode Island sure can't. The city of Providence just sent termination letters to every single teacher it has, 2,000 in all, in order to give themselves as much budgetary flexibility as possible. In fact, 34 states and the District of Columbia have already cut K-12 education programs, and 40 states have cut higher education over the last year due to budgetary problems. So today, this country is forced to stare at an inconvenient question. How can our children compete in a global economy without a quality education? President Obama has often said that we need to stick with this health reform proposal because it lets children up to age 26 stay on their parents' insurance policy. Well, Mr. President, when your economic policies make our college graduate children less likely to find a good job, they're going to need to stay on their parents' health insurance policy. And I yield back.
I yield this time 1 minute to Ms. Blackburn Tissey.
Thank you, Mr. Chairman. Welcome to our witnesses. Our chairman mentioned that the states were expecting the cost to be twice what the federal government had estimated. I would like to make everyone aware we have had a test case for Obamacare. It was in the state of Tennessee. It was called TennCare. Costs were not twice what were estimated. They were 4 times what were estimated. Mr. Chairman, our former governor, Phil Bredesen, had a great article in the Wall Street Journal on this. I'd like to submit it for the record, as well as a history ignored by Lee Pitts from World Magazine. This lays out what happens. TennCare ate up 35.3% of the state budget before it was addressed. There was no more money for higher ed, no more money for education. If you want a program that is going to eat up every dollar and is too expensive to afford, this is it. I'm looking forward to talking with our governors, Governor Patrick, looking forward to what you have to say about a failed program in your state, Massachusetts Care. Yield back.
The Chair will recognize for an opening statement the gentleman from New Jersey, Mr. Pallone, for 5 minutes.
Thank you, Mr. Chairman. Today we meet again as our Republican colleagues continue their assault on the Affordable Care Act and the many positive benefits it offers Americans nationwide. The specific focus on Medicaid in this hearing has little to do with our newly enacted health reform legislation. It's simply an extension of Republicans' decades-long interest in undermining and ultimately dismantling the Medicaid program. I'd point out that under Democratic leadership, the previous Congress understood the dire straits states were facing and granted significant federal relief through the Recovery Act to ensure that our safety net programs could operate as they were designed to provide Medicaid coverage for vulnerable Americans when they need it most. And this certainly should be contrasted with the recently passed Republican continuing resolution, which achieves nearly 1/3 of its budgetary spending cuts by reducing critical aid for state and local governments. It's no surprise to anyone that the Medicaid rolls are expanding right now. When the economy is contracting, Medicaid often expands, and vice versa. In challenging economic times, if unemployment increases and incomes drop, fewer people receive health insurance from their places of employment, and more individuals meet the eligibility requirements for Medicaid coverage. Now, we've been hearing a lot about the need for flexibility in the Medicaid program. States already have broad latitude to design their Medicaid programs after meeting minimum health care coverage benchmarks. They may also apply for Section 1115 Medicaid waivers to amend the program even further. But the flexibility my Republican colleagues seek seems more directed at destroying the Medicaid program than strengthening it. Block granting Medicaid is no panacea for states. It would threaten the fundamental tenet of the Medicaid program, that it can expand and contract according to need. By changing the federal component of Medicaid from a fixed percentage to a fixed dollar amount, states could be left holding the bag with much higher bills in times of economic crisis. It could be truly catastrophic both for states and for the citizens who desperately require medical assistance. And we should also be wary of proposals to raise cost sharing and co-payments on low-income and working families in Medicaid. Numerous studies, including one conducted by Rand Health, found that even nominal co-payments lead to a much larger reduction in the use of medical care by low-income adults and children, and seriously compromise access to needed health care. There are a lot more thoughtful ways to harness the cost of Medicaid than what our colleagues on the other side are proposing. The Affordable Care Act advances a common-sense philosophy regarding shared responsibility among individuals, employers, the federal and state government. The Medicaid maintenance of effort to protect access to health care for the most vulnerable is the state's responsibility in the near term until full health reform is reached in 2014. After that, 100% of the cost of the Medicaid expansion included in health reform will be borne by the federal government and then phased down to 90% in 2020. Furthermore, the Affordable Care Act enacted meaningful Medicaid reforms which slow the growth of health care costs for both states and the federal government. It promotes Medicaid demonstration projects and institute delivery, system reform, and finances state efforts to establish medical homes in Medicaid, which will improve care for those with substantial health needs. We also give the federal government and the states important new tools to fight fraud in Medicare, Medicaid, S-CHIP, and the state health insurance exchanges. We need to think carefully about the profound devastation some of the Republican proposals on Medicaid would have on working families and the state health agencies that serve them. I've been here for a long time, and it's almost every year we see another proposal by the Republicans to dismantle Medicaid. They don't like Medicaid, I know that. But the bottom line is that Medicaid has been a much-needed lifeline for the 6 million people that enrolled in the program during this recession, many of whom did lose employer-sponsored health insurance. I have a minute left, Mr. Chairman. I'd like to yield that to the gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman. Right now, across the country, and particularly in my home state of Wisconsin, we are seeing the effect of unfortunate attacks by some of our nation's governors on the values we hold dear. I'm sorry that Wisconsin's Governor Scott Walker declined the majority's invitation to be on this panel today. Governor Walker's budget adjustment bill would not only strip away workers' rights, it would also gut Wisconsin's Medicaid program. It violates Wisconsin's proud tradition of providing comprehensive health coverage for our most vulnerable citizens by potentially eliminating insurance coverage for 63,000 parents and 6,800 adults and reducing coverage for current and future enrollees. But Governor Walker's dangerous budget plan is also fiscally irresponsible. While Walker has offered his proposal under the guise of repairing the state budget and saving money, the proposed Medicaid provision would not yield any savings this year. Instead, the plan would put the state at risk for losing billions of dollars in Medicaid funding at a time when it can least afford to lose this funding. I stand in solidarity with my fellow Wisconsinites who have taken to the streets to oppose state plans to threaten the health, education, and safety of the people of our great state. I yield back.
Gentlelady's time has expired. At this point, quick thing. It's my understanding that the Democratic Steering and Policy Committee has approved Donna Christensen to be back with us, and even though the full caucus has not approved it yet, we welcome her back, and we'll view her as a member of the committee for all intensive purposes this morning. Without objection, I now will recognize the following gentlemen for 1 minute each to introduce their governors, Mr. Matheson, Mr. Markey, and Mr. Harper. Mr. Matheson.
Thank you, Mr. Chairman, for holding this hearing today. I want to extend a thank you. I'm sorry, is this microphone on? Hello. I want to extend a thank you to my governor, Governor Herbert, for providing Utah's experiences with reforming our health care system. As many on this committee probably know, Utah is one of the few states that took the initiative before enactment of health care reform at the federal level to tackle reforms to our health care system at the state level. One in particular was the establishment of a health insurance exchange in Utah. Our state's experience can certainly testify to the flexibility states need in order to implement this law. I appreciate Governor Herbert's participation in today's hearing. I want to extend him a warm welcome to our committee and look forward to his testimony and insight. I'll yield back.
Thank you. It's my pleasure to welcome Governor Deval Patrick from the great Bay State here to Washington. In 2006, Massachusetts trailblazed the path for the health care reform we'd see here on Capitol Hill just a few years later. Our outstanding governor has been the driving force behind successful implementation of the Massachusetts law. In November of 2010, he was overwhelmingly reelected to a second term. Under his watch, an astounding 98% of Massachusetts residents and 99.8% of our children now have good, dependable health insurance. No other state comes close. Just recently, Governor Patrick proposed new legislation to lower health care costs without cutting into our residents' quality of health care or access to services. His legislation focuses on quality of health care services over quantity, encouraging providers to better coordinate care for their patients. This means lower costs and healthier patients. Our experience in Massachusetts shows that far from being one-size-fits-all, health care and reform efforts provide states with wide latitude. I can't think of a better person than Governor Patrick to join us this morning to highlight the great work we've done in Massachusetts, and I look forward to his testimony. It is our honor to have you with us here this morning, Governor.
I'm honored to introduce one of today's witnesses, Governor Haley Barbour of Mississippi, who's made the tough decisions in Mississippi to make sure that we have a balanced budget and money in the bank, and has been a true leader on energy issues in this country. Governor Barbour has promoted a healthier Mississippi by supporting Let's Go Walking Mississippi, along with First Lady Marsha Barbour. The programs discussed in schools across the state to show kids the importance of exercise and healthy meals. Governor Barbour has worked diligently to protect the solvency of Mississippi's Medicaid program by controlling cost. Under his leadership, Medicaid changed its prescription drug program to better utilize generic drugs instead of more expensive brand-name drugs. He also promoted annual physicals for Medicaid beneficiaries to detect health problems early by checking them for diabetes and high blood pressure and making sure they're taking the right medications. But to truly understand Governor Haley Barbour, look no further than what happened in the aftermath of Hurricane Katrina to see what his leadership was about, what he and First Lady Marsha Barbour did. They didn't wait around. Governor Barbour didn't wait for somebody to come help him. He didn't wait for others. He didn't sit around and complain. He simply rolled his sleeves up and went to work, and the rest of America got to see what it takes to be a great leader. Governor Barbour, we're honored to have you today.
Thank you. Governors, welcome. If you take your seat at the table, and we appreciate your submitting your testimony in advance. At this point, we'll recognize each of you for 5 minutes each, and we'll begin with Governor Herbert from Utah. Welcome.
Push this on here, okay. Well, thank you very much. Good morning. I'm Gary Herbert, Governor of the state of Utah. I would like to thank Congressman Upton and other members of the committee for your invitation to testify here today. Let me begin by stating that I am a firm believer in the principles of federalism embodied in the 10th Amendment. A balance of powers between the states and the federal government is not only right and proper, but is essential to finding solutions to the complex problems we face today. Justice Louis Brandeis famously described states as laboratories which can engage in, quote, novel social and economic experiments without risk to the rest of the country, unquote. In Utah, we began our health system reform efforts 5 years ago, long before the Patient Protection and Affordable Care Act arrived on the scene. The lessons we've learned in our experiments in health system reform can serve as a guide to other states as they begin their own reform efforts. The federal government has taken the opposite approach, with a one-size-fits-all decree. The governors, the very people responsible for shoehorning the details of this decree into our agencies and budgets, were never invited to the table to give our input or ask for our opinions when the act was proposed by the Obama administration and debated in Congress. I find that frankly unconscionable. The states can and should find their own solutions, tailored to their own unique circumstances. In Utah, for example, a majority of Utah's uninsured populations are employed. Most work for small businesses that do not offer health insurance benefits. Utah also has the youngest population in the country. Many of our uninsured are the so-called young immortals who have deemed traditional health insurance coverage to be either unnecessary or too expensive. In order for health systems reform to be effective in Utah, we had to respond to the needs of our small businesses and their employees. As part of our health system reform efforts, Utah small businesses have the option of using a defined contribution model. This model allows employers to manage and contain their health benefit expenditures. With the creation of the Utah Health Exchange, Utah employees also benefit from expanded access, choice, and control over their health care options. Employees can now purchase one of more than 100 plans currently offered through the exchange. Our figures also show that 20% of businesses participating in the Utah Health Exchange are offering health benefits for the first time. Just as Henry Ford offered his first customers a choice of any color car they wanted as long as they chose black, the Affordable Care Act allows states flexibility in implementing the act as long as they do it the way Washington tells them. Another challenge for Utah is our increasing financial obligation for Medicaid. Even before the Affordable Care Act, Medicaid was already a large and growing part of the Utah state budget. In the 1990s, Medicaid took 9% of our general fund. In fiscal year 2010, it was 18%. By fiscal year 2020, it is estimated to exceed 30% of my general fund budget and that's without the federally mandated expansion of the Affordable Care Act. I've come to Washington to present solutions to help ease the burden on our state. First, I call upon the administration to support an expedited appeals process to the Supreme Court for the health care litigation. States cannot be left with uncertainty in regards to the implementation of this act. Second, I ask Congress to give states flexibility to find health care solutions based on each state's unique needs. And third, we have also proposed specific solutions for reform. These reforms will require that the Center for Medicare and Medicaid Services support our waiver requests. In the interest of time, I have included details of our recommendations in my submitted testimony, but I'll highlight just one example here today. In our efforts to be more innovative and efficient, we developed an approach which uses paperless technology to communicate with our Medicaid clients, reducing costs by the state of Utah as much as $6.3 million a year. With this flexibility in this one area alone, we estimate that all the states adopting this technology could save between $600 million and $1 billion per year. Communicating by email seems like a no-brainer. However, we waited for 8 months to hear from the federal government. When we did hear something, it was a denial. And in bitter irony, the denial came by email. Interestingly, when I raised the issue with President Obama just yesterday, I later received this note from Secretary Sebelius letting me know that we could now, in fact, proceed with the paperless process. Well, I appreciate this positive response, and I do. I have to ask myself two questions. First, why did it take a personal conversation between a governor and the President of the United States to resolve this simple issue? And second, and even more important, why do we even have to ask for permission to make this logical, cost-saving improvement? For me, this situation illustrates what is wrong with the current partnership between the states and the federal government, a partnership that is one-sided and puts the states in a subservient role. In conclusion, I emphasize again that real health care reform, I believe, will rise from the states, the laboratories of democracy, not from the one-size-fits-all approach imposed by the federal government. From the days of our pioneer forefathers, Utahns have been finding Utah solutions to Utah problems. I'm here today to assert our right and our responsibility to continue to do so.
Thank you.
Thank you.
Governor Patrick.
Thank you very much, Mr. Chairman, Mr. Waxman, to all the members of the committee. Thank you for the opportunity to be here today. Thank you, Congressman Markey, for the warm welcome and generous introduction. I'm looking forward to discussing with you the impact on the states of the Patient Protection and Affordable Health Care Act and the next steps in implementing national health care reform. And thank you in advance, Mr. Chairman, for your understanding about my having to leave by 11:30 to catch a plane to get back home. In the interest of time and with your permission, I will simply submit for the record the written testimony that we have provided and offer a shorter statement now. As many of you know, the Affordable Care Act enacted last year is modeled in many respects on our own reform measure in Massachusetts, enacted in 2006. Our experience with our own reform in Massachusetts may forecast what other states may expect from national health care reform in a couple of respects. Today, thanks to effective implementation of our 2006 reform legislation, more than 98% of Massachusetts residents have health care coverage today, including 99.8% of our children. As the Congressman said, we lead the nation in both categories. More people are getting preventive care instead of waiting until they have to go to the emergency room. Workers and their families no longer have to worry about a catastrophic illness forcing them into bankruptcy or being denied coverage because they're already sick. We have not had the problem of crowd out, where companies have abandoned insurance plans for their employees in favor of publicly subsidized plans. In fact, the percent of private companies offering health insurance to their employees has increased from 70% before the bill was passed to 76% today. We paid for expanded coverage just as we said we would, by delivering more care in primary care settings than in emergency rooms. In 2005, Massachusetts paid over $700 million for health care for the uninsured and underinsured. In 2011, we spent $405 million, nearly $300 million less. With 98% of our residents covered, universal coverage has increased state spending by about 1% of our total state budget. Overall, Medicaid represents 32% of annual state spending today and has grown about 2.7% per capita since our reforms were enacted. Ours is a hybrid solution. Like the Affordable Care Act, it emphasizes private insurance purchased in the open market at competitive prices and service delivered by private clinicians. People choose their own doctors. We still have challenges, of course. For example, even with the highest per capita ratio of primary care physicians to residents in the country, there are not enough primary care physicians. The wide variance in the reimbursement rates of provider hospitals is another challenge. But these are challenges all over the country. The point is that in Massachusetts, we stopped limiting our thinking to the same old two choices between a perfect solution or no solution at all. We chose to try something, and we moved, and it has worked. The process of developing our reform measure is something I'm proud of, too, and I just want to touch on very briefly. Then Governor Mitt Romney, a Republican, working together with a Democratic state legislature, a Democratic United States Senator, Ted Kennedy, and a broad coalition of business and healthcare leaders, labor, patient advocates, came together to invent our reform bill and then stuck together to adjust it as we've gone along and to refine it. That bill was an expression of shared values, of our belief that health care is a public good and that everyone in Massachusetts deserves access to it. So for Massachusetts, the Affordable Care Act is familiar. Like our law, it improves health security for all our citizens. It takes a hybrid approach that leverages the best of government, nonprofits, and private industry. And with President Obama's leadership, it was developed and supported by a broad coalition of stakeholders and advocates who understood that our public health and economic competitiveness demanded action. The Affordable Care Act is also cost-effective. According to the Congressional Budget Office, the Act will reduce the federal deficit by $124 billion through 2019 and by more than $1 trillion in the subsequent decade. So national health reform is an important piece of a responsible plan to improve our fiscal outlook for the long term. Now, based on our experience at home, national health reform is also good for our economic competitiveness. Matt McGinnity, the CEO of a small technology company in Natick, a town outside of Boston, bought health insurance through a program created by the Commonwealth Connector, which is our version of a health exchange. The program, called Business Express, is an online service to help small businesses easily shop for private health care and find the best possible value. Using Business Express, Matt was able to compare health plans side by side and avoid a 23% premium increase his current insurer was proposing. He and his employees saved $9,300. Now, that may not seem like much to many of you here, but it is meaningful to Matt's company and to thousands of small businesses like it in our home state of Massachusetts. I met a young entrepreneur recently who moved his business up to Massachusetts from Florida. I hope I'm not upsetting anyone here from Florida in saying this, because with a young family, he wanted to be able to start his venture without worrying that his children would not have health insurance. In other words, universal coverage has helped our competitiveness. So federal reform, I see my time is up. Let me just wrap up, and I hope we can get to what I feel is the nub of the issue, which is cost control. And cost control is a challenge all over the country in places that have a universal system and in those that don't. 130% premium increases over the last decade. And we have some strategies that we have put in place and that we are pursuing in Massachusetts to get at that nationwide issue. And frankly, there's some elements of the Affordable Care Act that help us in that regard as well. And I look forward to your questions. Thank you very much, Mr. Chairman.
Thank you. Governor Barbour, welcome.
Mr. Chairman and members of the committee, first of all, thank you for asking. I mean, the first thing we want to say is thank you. When they were doing the Affordable Care Act, there was a big meeting at the White House of members of Congress from both parties, and there were no governors. And so thank you to the committee, for both Republicans and Democrats, for asking governors what we think. I would like to associate myself with Governor Herbert's request that the cases from Florida and Virginia on the constitutionality of the federal act be expedited. It's in our interest to know the answer sooner rather than later. And the thing we fear the most is conflicting opinions from different circuits. We've already seen conflicting opinions at the district court level. Conflicting opinions from different circuits would just compound that problem. So For those of you who have any influence on that, we would like to get that question answered sooner rather than later. I'm delighted to be with my friend Deval Patrick. Massachusetts has a state health insurance program that they're obviously happy with. And we think that's their right. And when Senator Kennedy and Governor Romney and then Governor Patrick, if that's what Massachusetts wants, we're happy for them. We don't want that. That's not good for us. We don't want that. We don't want community rating. We don't want extremely high mandatory standard benefits packages. So the point I'm trying to make is different states have different problems. We have different ideas. And while you may not believe it, some politicians, obviously, who act like y'all love our constituents more than we do, believe it or not, we love our constituents as much as y'all do. And we want to do right for them, but we want to do what we can afford and can sustain. Medicaid's the second biggest item in my budget after education. We spend about 63% of the state budget on education, and Medicaid is the next biggest thing. However, Medicaid's growth before I was governor, it was growing at 16.5% a year, and we were cutting our community colleges and cutting our universities because of the money was having to be diverted to Medicaid. In my 7 years as governor, we've reduced Medicaid expenditure growth to 4%. We have not changed eligibility, with one exception. The people who we used to give pharmaceuticals through the Medicaid program, who are dual eligibles, now get their pharmaceuticals through Part D. So, in full disclosure, I want to say that. The reason I do is because of this. Because we've got the flexibility to do it, we reduced our pharmaceutical program's cost from $697 million annually to $279 million, a 60% reduction. A little bit of that came from Part D, but primarily by going to generics. We're 78% generic now, and the meds are great for people. If somebody cannot, doctor, if they have to have brand name, we do that. Flexibility to do that kind of stuff is critical for us. That's what we need. One of the things we were allowed to do my first year is our Medicaid roll had gone from 510,000 to 750,000 in 4 years. Forgive me for thinking maybe that wasn't the way it should have been. So we found out that the previous administration had not followed the federal rule that you have to require people to reestablish their eligibility annually. They weren't doing that. We require our beneficiaries to reestablish their eligibility annually in person. And a lot of people who probably had once been eligible for Medicaid, but weren't anymore, didn't come to try to requalify. We make exceptions for people in nursing homes, for disabled children, for people who are homebound because they're sick. But this is a benefit on average that's worth somewhere between $6,000 and $7,000. We don't think it's a burden once a year to go to one of about 70 places just to reestablish your eligibility for this program. We do that for everybody. What we would like is the ability while they're there to mandate that they take a physical. We offer at this meeting every Mississippi Medicaid beneficiary a health assessment, and hardly any of them take us up on it. We would like to be allowed, and we don't think we ought to have to ask for permission to make that mandatory. But there are a lot of things you have to get permission to do. Waivers are a problem you'll hear from many people, but I want to tell you, state plan amendments can be just as big a problem. We have a state plan amendment where they met the 180-day requirement to approve our state plan amendment, but then it took them a year to approve the contract that was going to be part of the state plan amendment. And that doesn't help. Let me just make one other point about this, and I know my time's up, but I think it's important. We have $7 million in Medicaid that comes from fines paid by nursing homes that had some violation. We have to get CMS's permission to spend that. We asked for permission to spend it to build a facility for the 20 to 25 very sick children, typically vent patients, that right now we either have to put them in a hospital, very expensive care, or send them out of state, because the regular nursing homes are really not set up to have 79 senior citizens and one 5-year-old. We were told, well, you can do that if you remodel an existing building, but you can't do it if you build a new building on our University Medical Center State Hospital campus. Those kinds of things we should not be required to ask permission to do those kinds of things, whether it's to save money or provide better care. My time's up, and I'll be glad to take any questions.
Thank you all. We will ask questions alternating between sides until you all have to get on your planes to go back. Again, we appreciate you being here. Governor Herbert, you mentioned that in Utah you have nearly 100 different exchanges that folks are able to participate in. Has your state examined how many of those would still be around when the Affordable Care Act would be fully implemented?
Well, it's uncertain. The hope is that we'd be able to maintain our exchange even during the implementation of the Affordable Care Act. That's part of the discussion right now, for states to do their own exchange, or the federal government will come in and do one for you. I think that because we've got an early run on this, that we're probably going to be able to maintain. We have 100 plans and a number of different providers, and it's growing. And small businesses, for the first time, are finding a way to provide a benefit package of health care. So our exchange is working the way we thought it would work. It's only cost us about $500,000 to $600,000 to set it up. And so we only have about 3 people on staff that are running it. So it's a very different approach than Governor Patrick's, and I'm not saying it is the approach. It is a approach. And I would just echo what Governor Barber said. You know, all states ought to have opportunities to find the solutions to the problem. And so ultimate flexibility is probably what we need, and I think we'll find solutions to the health care issue that represents the demands and needs of our own respective states.
Now, as I understand it, many of your plans are health savings accounts, HSAs. Does your state anticipate seeking a waiver to try and keep those alive then?
We don't have health savings accounts that have been put into place, or at least in any dramatic form right now with our health exchange. What we've provided really is a defined contribution as opposed to a defined benefit, where the small business people now can identify how much money will you put towards health care. Then the consumer takes that money, goes to a portal of information, and then shops for whatever's best for them in their own individual interest. And introduces private competition as people search for their business and try to compete. And it puts the consumer in control of that money. And so similar to health savings accounts, it allows the consumer to spend the money as they see fit, as opposed to how the insurance company sees fit or the business sees fit. There's not a third-party purchaser now, it's not a one-size-fits-all for the individual.
Okay, last question, Governor Herbert, Governor Barber. As you look at expanding the Medicaid population up to 138%, how is your state going to be able to pay for your state's share of that expansion?
Well, again, the eligibility requirements going up is going to cost my state an additional $1.2 to $1.3 billion over the next 10 years. And for a state the size of Utah, that is real serious money. And the only way we can afford to do that is we're going to have to cut from some other program, whether it be education or health and human services in other areas, or transportation needs that we have in a fast-growing state, or raise taxes, which will probably have a dampening effect on our fragile recovering economy. So the options are not good for us with that request.
And Governor Barber, how would you respond to that?
It's going to take a very big tax increase. The federal act would require us to increase the rolls by about 2/3, from about 600,000 people, 20% of our population, to 1 million, 1/3 of our population. And because the costs are backloaded, you know, the first few years are very little cost, $1.3 billion to $1.7 billion over 10 years, but by year 10 it'll be $443 million is the estimate. $443 million is a gigantic increase in our taxes, but that is what it would cost us.
Yield my balance of my time to Mr. Guthrie.
Thank you, Mr. Chairman. Thank you for yielding. That was the question I was going to go for. Just 3 years ago, I was a state legislator trying to make the budget balance, and if you looked at Kentucky's pie, Medicaid kept getting a bigger piece of it, and we had to take it out of higher education. Tuition rates are higher, other things are higher in Kentucky because of the growth of Medicaid. And now Governor Beshear said essentially what you said. He said, I have no idea how we're going to pay for it. That's a quote. And just get into further, what is this going to do to education or other issues? I know Governor Hebert touched on it a little bit, but Governor Barber, alphabetically we can go, just have a few seconds, but what this is going to do to your state budgets if we don't give you as it's written.
Because we can't run a deficit. You know, we either have to raise taxes and cut spending for other things, or more likely do both.
Governor Hebert? Governor Patrick, going to have an effect, or
yes,
Governor Patrick, is that going to affect
our increase, as I mentioned, I think earlier, is that for us it'll be a 50% increase in Medicaid eligibility. So it's a dramatic increase in our budget, and again, the 1.2 to 1.3 billion dollars additional cost has got to come from someplace. Either you raise taxes or you cut services. It's that simple. And as a state legislator, you know the challenge that is. We're all having challenges with our budgets today. It's a very difficult time, and this just adds to the problem.
Does it affect Massachusetts different, Governor?
Excuse me, my time has expired.
Okay.
We yield to the ranking member of the full committee, Mr. Waxman, for 5 minutes.
Thank you, Mr. Chairman. Thank you, Governors, for your testimony. It seems to me in both your oral presentation and your written testimony there are some common themes that I think we all can agree on. We must continue to make Medicaid a better program. By innovating, we can provide better quality of care while also reducing costs, and I think we need to work together to achieve that goal. But we also know nationally that certain populations have greater health care needs than others. Children are half of Medicaid's beneficiaries, but they're only 25% of the costs. Adults, including pregnant women, make up 23% of beneficiaries, but 13% of the costs. Individuals with disabilities make up 19% of the population, but 44% of the costs. And seniors make up 10% of the beneficiaries, but 23% of the costs. And this is the same for all three of your states. Children and adults make up the largest share of the Medicaid enrollees, but they're only a fraction of the cost. That's why it doesn't make sense to cut back eligibility for adults and children. First, cutting back on eligibility for adults and children will save the state some money, but not very much, because these populations are not where the money is. Secondly, uninsured low-income kids and adults use the emergency rooms more than they would if they were insured and had a source of primary care. But the real problem is that the cost of that care is now going to be shifted to the emergency room, the physicians that staff it, the hospitals that operate it, or onto the people themselves who won't be able to get the services. The costs, like the people, don't just disappear once eligibility is terminated. They're just taken off the federal and state treasuries and shifted onto local community hospitals, physicians. That's really inefficient and unfair. So where is the money in Medicaid? Over half of the spending is for seniors and the disabled. And cutbacks on the disabled and seniors are unthinkable, as these are some of the most vulnerable and medically needed in our society. So I come to the conclusion we have to be smarter, we have to do things better, and under the Affordable Care Act we can. For example, under the Affordable Care Act, we're already helping states and providers create demonstrations to structure and implement new delivery models to reduce costs and improve care for the dual eligibles, as Governor Barber pointed out. That's the most expensive population of seniors and disabled. Governor Patrick, I heard you touch on delivery system reform in your opening statement. Can you talk about why you decided that expanding coverage and improving the quality of care are the right direction for us to move in, as opposed to cutting back on eligibility?
Thank you for the question, Congressman. First of all, I just wanted to say that as we have implemented and expanded coverage, our universal plan over the last 4 years, we have also increased spending on public education every single year. to the highest level in the history of the Commonwealth, because that is another values choice that we have made. And for us, the discussion about whether to try to insure everyone or not is a question about what kind of Commonwealth we want to live in, and I would suggest that the discussion about how to do that nationally is also about what kind of country we want to live in. The question of cost is a question that is with us, that is facing small businesses and working families, whether we have Affordable Care Act or not, whether we have Medicaid or not. And that's what we have focused on now. That's our next chapter in health care reform, and frankly, we get some tools through the Affordable Care Act to help us with that. It turns out, from the perspective, and I'd be interested, I know I'm not supposed to be asking the questions, but Dr. Bridges, I wonder if this...
Please don't.
What's that?
Please don't, because I only have a limited time. But your idea is to hold down costs by innovating in the delivery system, not cutting people out of the program. Now, Governor Herbert... Oh,
I was just going to say that what we have learned from clinicians, from medical professionals, is that more integrated care is actually better care for the patient in terms of quality, but a lower cost care as well. And so realigning the incentives so that we are paying for quality of care rather than quantity of care is where we're trying to move now.
Okay, thanks. And Governor Barber, I have a quick question to ask you. We have some areas of agreement as well. Support for medical homes, which is also authorized by the Affordable Care Act. But I want to focus on the eligibility cuts right now. You promoted the idea of flexibility that would allow you to cut eligibility. So my question for you is the following. Do you intend to cut eligibility for the inexpensive adults and children, possibly flooding your emergency rooms without reducing the cost substantially? Or do you plan to cut off seniors and the disabled, since that's where the bulk of the Medicaid spending is?
Thank you, Mr. Waxman, Congressman Waxman, for asking. As I said in my testimony, I reduced the cost increase of Medicaid from 16.5% per annum to 4%. We didn't do it by changing eligibility, except when the federal government set up Medicare Part D, there was no reason for us to have a pharmaceutical program anymore to duplicate that. It's a very small part of the savings. You're right. Children cost us about $1,000 a year. Our average beneficiary costs us between $6,000 and $7,000 a year. That's where the savings are. The savings are in managing. We can give these people better care at the same time, but we shouldn't have to come up here and kowtow and kiss the ring to get the permission from Washington to do that, to try to help our people. That's what we're saying. And, sir, we would be willing to make this deal with you. Give us a block grant with total flexibility, and we will say limit the increase in our FMAP payment to half of the national average, whatever it is. And we'll take that in a heartbeat.
Thank you.
Chair recognizes the gentleman from Texas, Mr. Barton, for 5 minutes.
Thank you, Mr. Chairman. It's good to have you three governors here. This is kind of deja vu. We did this 6 or 7 years ago. Governor Barber was a big part of that at the time. We have a new governor down in Georgia, Nathan Deal, who is a former subcommittee chairman of the health subcommittee of this committee. And when he was subcommittee chairman and I was full committee chairman, we passed an amendment that gave the states the right to actually verify eligibility, verify citizenship. We didn't say that states couldn't cover illegal aliens, but we said if you wanted to restrict your benefits for Medicaid to U.S. citizens or legal residents, we gave you the right to do that. Our friends on the Democrat side changed that verification program to basically self-affirmation. If you say you're eligible, you're eligible. Governor Barber, would one reform of Medicaid that we should consider be going back and giving states the right to actually verify citizenship before they're extended Medicaid benefits?
Yes, sir.
Governor Herbert, what's your advantage?
Absolutely. I think that would just make sense.
Governor Patrick.
I think we do it already.
You think you do it already? Well, I'd like to see your program then, because if you do, you're the only state in the nation that does. So I appreciate that. There's been quite a bit of talk the last Congress of states beginning to opt out of Medicaid because it just gets too expensive. What would the tipping point be if we don't change the current health care law? Where would states begin to seriously think about opting out? At what point of their budget? As in Texas, for example, 25% of the state's budget is for Medicaid. In some states it's higher than that, and in some states it's lower. Do the governors have a task force on this issue? And if so, what discussion has been about where states begin to seriously think about opting out? Again, we'll start with Governor Barber and just go right down the line.
I do notice that I'm on Governor Patrick's left, but I realize to y'all I'm on his right. That makes me feel better, and I think it makes Deval feel better.
At least y'all can joke about it. That's a good thing.
I can't imagine Mississippi opting out of Medicaid. We're a poor state. It's an important program. We just want to run it better. We want to run it better for the taxpayers. We want to run it better for our beneficiaries. We can control the cost much, much better if the federal government would give us more flexibility, or just make it where we didn't have to go ask for permission like Governor Herbert was talking about for 8 months to do something very commonsensical. We could, and that's in your budget interest too. So I am not an opt-out advocate, and I'm just being forthright about it.
Governor Patrick.
Congressman, as I said in my opening statement, we are so far down this path. We have the Affordable Care Act is very familiar to us because in its framework, because we have reform measures in Massachusetts that are very like it. So this is not so scary to us. I think there is a bigger question here that goes beyond Medicaid and goes to the private payers as well, and that is, as I said earlier, the escalating costs in insurance premiums that have been with us all over the country, certainly all over the Commonwealth. And that is where we have concentrated our time. Okay. We get some additional tools because of the Act to get at that. And I would just say respectfully, it would be wonderful to work with the Congress on that larger issue, because I think that is enormously important for our competitiveness economically.
Okay. Governor Herbert.
Well, thank you, Congressman. I think it's like asking the question, which straw will break the camel's back? And we don't know which one will break the camel's back. We keep piling it on, and eventually we're going to have some serious back strain. In Utah, again, we're doing pretty well with health care. President Obama, in fact, has used Utah as an example as he's advocated for better health care. We have good quality health care at lower costs in Utah, comparatively speaking to other states. So our system really has been working pretty well.
So y'all don't see us, any state really, in your experience, thinking about opting out?
You're saying opt out of Medicaid.
Medicaid, that's correct.
I don't.
Yeah, we have no plans to opt out of Medicaid. Our concern is really the increasing costs of Medicaid, and the majority costs to Utah for the Medicaid expansion are coming from the healthy low-income adults.
Okay. Mr. Chairman, my time is about to expire. I'm going to submit for the record a question for them to expand on the constitutionality of federal mandates that the states have to pay. And there are a lot of federal mandates in this Medicaid expansion that beginning in 2014, 2016, the states have to do it, and they have to pay for it. And I'd like a response in terms of the constitutionality of that question, but I'll put that in writing for the record.
Thank you. If you can respond quickly, that'd be great. Chair would now recognize the gentleman from the great state of Michigan for 5 minutes for questions. Mr. Dingell.
For your courtesy, gentlemen, welcome. I'm delighted to see you, Governor Barber. We are old friends, been on the same side and opposite sides of many questions together. Governor Patrick, welcome to you. We're proud of what you're doing up there in Massachusetts. Governor Herbert, welcome to you.
Thank you.
Gentlemen, very quickly, I note, Governor Patrick, you've had firsthand experience in implementing a state-level reform law, and that you support the federal law and find that it will work well with your statutes up there. Is that right? Governor Barber, I gather you, my old friend, have a different view. You've supported overturning the law. Am I correct?
That's correct, Mr. Chairman.
And Governor Herbert, I gather you've also supported overturning the Affordable Care Act. Is that right?
We've joined in the lawsuit in Florida.
Now, gentlemen, I want to see where we are. We have embarked upon a great challenge and upon a great testing of our national will and capability here. And so let's go through some of these things. In the case of Mississippi, Governor Barber, you are aware that the health care insurers can no longer discriminate against 180,000 children in Mississippi with pre-existing health conditions. And you're also aware that as a result of the Affordable Care Act, about 53,000 businesses in your state, as in other states, will be eligible for $350 million in new health care tax credits. And Governor, you're also aware that 1.5 million residents of your fine state are benefiting from consumer protections in the Affordable Care Act, such as prohibit annual and lifetime coverage bans and limits, ban on rescissions, and provide safeguards against unreasonable care increases. Now, and you, Governor Herbert, thanks to the Affordable Care Act, find that 20,000 seniors in Utah have already received $250 rebates from high Medicare drug prices as a matter of relief. And again, in Utah, the Affordable Care Act now permits 270,000 Medicare recipients in Utah to receive free preventive care. And in Utah, again, I note that the uncompensated care costs borne by Utah hospitals and healthcare providers will be protected against over $1 billion in the next decade. And also that in Utah, the Affordable Care Act, there are over 200,000 otherwise uninsured state residents that will be able to afford and to obtain affordable health and effective health coverage. Now, gentlemen, we have all this before us, and I'm trying to understand. If you could assist me, you could start with you, Governor Herbert. Remember, I don't have much time left. What are we going to do to replace these benefits if we repeal them? How are we going to make whole the categories of persons that I have just mentioned who will be significantly benefited?
Well, I think, as Governor Barber has mentioned, that we really do care about our people in our states, and we'll find solutions.
That's not an issue, Governor. I don't want to get into that debate.
Okay, it seems
it's not
like
a proper debate.
It seems like the approach from Washington is do it our way, or it won't get done. Again, Utah has good health care, has had good health care. I guess, come from the position that as we look to those who need the benefits, and we define what those benefits are, there's nobody can define them better than the governors and the people in the states. So the eligibility, the benefits that ought to be received, we can help define that better than anybody, I think, else, certainly better than people in Washington.
I apologize. I've got 58 seconds to share between your two colleagues.
Chairman Dingell, thank you. A couple of points. Most of our small businesses won't qualify for those subsidies. However, the standard benefits package that we expect to be put on us will cause many of our small businesses that today struggle to provide health insurance to their employees will drop that health insurance because the standard benefits package is going to drive the cost so high. As far as the pre-existing condition, we recognize this issue in Mississippi long before Haley was governor. And for about 15 years, we've had a pool, a risk pool, for people with pre-existing conditions. It has about 3,600 people in it right now, and that's about average. As you can imagine, people move into it, and then when their pre-existing exclusion expires, they move out. The federal risk pool has 58 people. Even though the cost is less, the premium is lower. And so this is just an example of something that, I don't know, I'm told 35 states have a risk pool like us, or similar risk pool. There are things that we can do, and we're doing them, and we think we should be allowed to make those decisions instead of having community rating, high mandatory benefits package increase the cost of health insurance in our state.
Governor,
that's our concern.
Governor, I just want to hear a word from Governor Patrick. Governor?
Well, we see a tremendous amount of flexibility in the Affordable Care Act today. We see some further benefits in terms of federal tax credits for the next tier of people we're trying to reach. We see some tools to help us get at the dual eligibles, which is a number have mentioned, and I know my colleagues agree, is a particularly expensive part of the health care system. And we see some flexibility to try new things in terms of payment delivery systems and payment reform, which is where the real pickup is, not just in Medicaid, but for the health care cost system generally. So for us, this is a good bill and one worth fighting for, and we intend to fight for it.
Mr. Chairman, I thank you for your courtesy.
Gentleman from Illinois, Mr. Shimkus, 5 minutes.
Thank you, Mr. Chairman. Mr. Chairman, I want to submit a rundown of the state of Illinois' issue. I don't want to go through it, but I want to submit that for the record. Thank you, governors, for coming. Utah and Mississippi both run about a $700 million deficit right now. That's what I'm being told, where Massachusetts has a $1 billion deficit. You all have balanced budget amendments. Illinois is $13 billion in the hole. Do you believe that the Obamacare or gives you the flexibility to address changes in Medicaid to help get such a large budget deficit under control? Shortly, yes, sir. Just each one.
In Utah, our structural imbalance, we have no deficit. We have a structural imbalance. We use some one-time money. We're not borrowing it. Is about $200 million. But this clearly, the cost to us as we move forward with the Affordable Care Act will throw that out the window.
So it doesn't give you the flexibility to meet your budgetary needs?
Well, again, it doesn't give us the flexibility. I guess the definition, how flexible is flexibility? You know, there are some flexibilities in it, but again, if we have to maintain maintenance of effort, if we have to, in fact, use the...
Okay, I'm going to try to get through. I don't want to be disrespectful, but I want to get... it's moment we'll say yes. Governor Patrick?
Yes.
You think it does give you the flexibility? Governor Barber?
Well, of course, the difference is I don't have his state health care system. Under ours, it would drive up my cost. It would absolutely make a very large tax increase necessary. But more importantly, it will drive up the cost for health insurance for the individuals and the businesses that buy health insurance.
Right. Thank you. In Illinois, it's $13 billion in debt. That's our financial position in the state of Illinois. If members of the congressional delegation would write you a letter saying, hey, Governor, we know you got issues. Can you get with your health and services people and let's start talking about how we can jointly help solve this problem? Would you, as a governor, be open to a letter by members of the congressional delegation to address your concerns? Governor Eber?
Absolutely.
Governor Patrick?
Well, I'm not sure I understand the question, but we've been working closely with our delegation.
Well, this is Medicaid. We have a large role in the Medicare delivery system. We are partners with you. If your members of Congress said, we want to help you, would you say, yeah, come on,
I've
help
never
me?
said no when our members of Congress...
Thank you. That's what I...
Yeah, that was the answer, yes. I think, to her credit, Christine Gregoire, who's the chairman of the National Governors, a Democrat, by the way, is trying to do just that. And the fact that y'all are having governors here is encouraging.
Just for the record, in November 2009, we sent a letter to our governor, and we have yet got to get a response. One that has $13 billion in debt based upon Medicaid. I'm going to address some really quickly cost issues. If we're going to try to help contain cost, EMTALA, which is the emergency room law that anyone who walks in the door has to be received, even though it's not an emergent issue. Mm-hmm. If we addressed EMTALA and we're able to triage and push people to urgent care, that would be a reform at the federal level. Would that help you control cost?
I think it would. It needs some analysis by experts in our state, but I think so.
Governor Patrick?
Yeah, I think it could, and we've been taking those very steps.
Yeah, it's great.
I would urge you to give us permission for us to do something rather than telling us how to do it.
Great. What about Obamacare had, when we're talking about saving costs, it was $50 billion of savings if we would move on tort reform, lowering costs. $50 billion which could have gone to pay some of the expensive costs of promoting it. Would tort reform be a good way to hold down costs, Governor Herbert?
Absolutely.
Governor Patrick?
In the bill I referred to earlier, which is our next phase of health care reform, we have included tort reform in that, yes.
My first year as governor, we passed the most comprehensive tort reform in the country. It doesn't just help cost, it improves the quality of care because we had doctors leaving to get away from lawsuit abuse, and so it is more than cost.
Last question. Under on federal law, we give in federal qualified health clinics, we give them Tort Claims Act protection. If we're providing health care, Medicaid dollars, federal dollars, if we provided federal Tort Claims Act protection for practitioners who are receiving federal dollars, would that help drive down costs, Governor?
I think so, yes.
I don't know how to answer that.
Well, it's a tort reform issue, so.
Under our state Tort Claims Act, the University Hospital and all, they have caps under the law, and it does help.
Thank you very much. Yield back my time.
Chair, I would recognize the gentleman from New Jersey, Mr. Pallone, for 5 minutes.
Thank you, Mr. Chairman. I wanted to go back to Governor Patrick because I know that in response to Mr. Waxman, you were basically talking about how more quality care or improving coverage and quality care actually lowers costs. And I really believe that. If you cover more people, you give them quality care, then ultimately you save the system more money. And I at the risk of being critical of the Republicans, I'm going to be anyway, you know, I just think it's ironic because if you go back a few years, you had people like Governor Romney who were advocates for universal coverage because it, you know, saved money in the long run. I remember when the second George Bush was president, he was a big advocate for expanding community health centers. Now we see the Republicans in their continuing resolution cutting community health centers. Even the FMAP, you know, that gave more money to the states. That was a big thing with the Republicans, too. Peter King introduced the legislation back in 2003, long before the Democrats were even doing it. But now we see all these, you know, now we see the opposite. We see, you know, Republicans backtracking and say that they don't support these efforts to expand coverage and provide the community health centers with funding. I want to issue two things, Governor Patrick. One is if you just want to expand a little on, because I don't think you had a chance on what Congressman Waxman asked about, you know, what Massachusetts did to expand coverage and how that actually improves quality, makes for healthier people, and in the long run lowers costs. If you just, you know, maybe spend a minute or two on that, because
Thank you for the question, Congressman. The simple fact is that more people in Massachusetts today get their primary care in primary care settings than in higher cost emergency room settings, and that means system costs are smoothed out. And it's a simple principle of insurance that more people who are insured, the more you spread the risk, that also moderates costs. But premium costs, which is the, you know, the provider rates, although there is variance, they have increased faster than inflation in Massachusetts and everywhere else in the country. This has nothing to do with universal care. This has to do with the way we incent, if I may use that as a verb, the way we the incentives for how we pay for health care. Right now, we pay for the number of times you're in and out of an office, the number of tests that are run, and not the quality of that care. And managing that care closely, particularly for those high-cost, chronically ill people, has been shown to be better care for the individual, but also lower costs. So what we have in the Affordable Care Act are tools we didn't have in our own health care reform, and that we are building on now with a new piece of legislation I filed 2 weeks ago to realign these incentives and get it system-wide costs. And that is good, not just for the state and for local budgets, but that's good for business budgets and for working families.
Well, I appreciate that. And again, I didn't hear Mr. Barber criticize Mitt Romney, but I know he's got, and thankfully for that, but I know that he gets a lot of criticism, and he was the one that basically came up with this idea, or was a governor at the time in any case. Now, I wanted to ask about community health centers, because this is another case. You know, when I was here and George Bush, the second George Bush was president, he really pushed for community health centers, opened more of them. You know, this was going to be our answer for people who didn't have coverage. Now we see in the CR, community health centers, I guess, are cut by $1.3 billion relative to the president's request, and that would roll back critical expansions to community health centers. In your state, Massachusetts, you would lose nearly $5 million in community health center funds, which are being used to provide care for nearly 90,000 of your residents. I had a community health center that was funded in the Recovery Act, wrote me a letter saying now that they'd have to close the door if the CR becomes law. So, how's your state going to fare if these funds are cut off? I mean, community health centers are a way, if we don't have Medicaid or the Medicaid gets cut back, people at least can go there. It's another backup.
No, I understand the question, Congressman, and it's a worry for us. We have a broad and deep network of community health centers, and frankly, the community health centers, like the community hospitals, tend to be lower cost settings for primary care than the wonderful downtown teaching hospitals that we have. And for our system to work, and I think for Universal's system to work, we have to have more community dispersion in where people get their primary care. So we very much are watching and involved in trying to assure that just as we keep up our end of the bargain in terms of our support for community health centers, that the Congress does as well.
Thank you.
Mr. Pitts, 5 minutes.
Thank you, Mr. Chairman. Thank you, Governors, for coming. Governor Barber, you mentioned that a couple of years ago you started a new program for persons to individually sign up for eligibility. I didn't hear, after that first year of requiring individuals to sign up personally, what happened to your rolls? What percentage was the effect of that?
Congressman Pitts, it was a combination of 60,000 more people working in my state, Part D, but our program, we reduced the rolls from 750,000 to 580,000.
It's about 20%?
About 20%, that's right. And again, there's nobody who's not getting health care. There were a lot of people who weren't eligible.
Yeah. Now, under the maintenance of effort requirement in the new law, can you continue that program of having people individually sign up for eligibility?
My understanding that we can.
That you can?
Yes, sir.
Can you elaborate on your state's experience in dealing with the CMS bureaucracy and your attempts to be granted Medicaid waivers? Do you find the CMS bureaucracy helpful and cooperative? Do you find their decision-making process timely? Do you find their actions too burdensome? Would you elaborate?
My experience over 7 years as being governor is there are a bunch of nice people who work there and they work hard. I've actually been up to their headquarters a few years ago to go through a really kind of complicated issue. But for whatever reason, it's slow. And I am told that the average waiver takes a year. I have been through personally in the last 15 months a state plan amendment and contract that took 15 months. And at the end of 15 months, it was approved, except they told us you can't do the part that actually helps. You know, they didn't approve that part of the contract. These are things that we shouldn't have to come up here and ask for. We ought to have the flexibility to run the program. But I don't think it's because they're not good people or they're not working hard. It's just the process is long and drawn out.
Thank you. Governor Herbert, you mentioned an anecdote. Could you elaborate on your dealings with CMS bureaucracy?
Well, again, I've already given the example of wanting to go paperless, which, again, I think most people here can see that's kind of what we are about today. And it's a voluntary basis, so that you don't have to do it. It's not mandated, but it would save us about $6.3 million. But after 8 months, we were getting nowhere. I actually came to meet with CMS to get things moving. We couldn't understand why we were getting a denial, and the denial being sent by email we thought was just ironic. And that kind of got things moving, but it was really the conversation yesterday with President Obama that allowed us to finally get this logjam removed and do something that is just sensible. But we have other waivers out there that we want to look at that we allow us to, in fact, put together a Medicaid rainy day fund to help us slow down the costs that are rising in Medicaid, to start providing fee-for-service to payment for healthy outcomes, not just for procedures, to incent on the right side of the health care equation. But that will require some waivers from CMS to allow us to go forward. So, again, we'll come up with ideas. Other states will come up with ideas. But we need to have the ability to have this dialogue and get some waiver to allow us to find efficiencies in the system.
Thank you. Governor Patrick, during the debate on the Obamacare law, the proponents of the law stated passing the bill would get people to stop using the emergency room for their care. In Massachusetts, do Medicaid patients visit the ER more or less than those with private insurance?
About the same.
Now, I have a study, September 2011 paper by Douglas Holtz-Eakin, suggesting that from July 07 through March of 08, Medicaid patients visited the ER at a rate more than 3 times those with private insurance. Do you think that figure is in the ballpark?
No, that figure is not current. It's about the same, and the total population has gone down. We started implementing health care reform, Congressman, in 2007, at the beginning of 2007, so we've had a little bit more of 4 years of getting at that, and total utilization in the ER for primary care has gone down in both the private payer and public payer.
A half minute and a half left. I'll yield to Dr. Cassidy.
Thank you.
I'm sorry, just before you, if it's all right, do you mind if I also say something about our experience with CMS?
Go ahead.
I would just like to, we've negotiated now 2 waivers with CMS in order to do our own experiment, and I want to say that our experience has also been a very deliberate, very sometimes feeling tedious experience with the current administration and the administration before. Now, when we have raised these issues in the past, they have expressed what I think is the perennial concern, which is that they know that they also have, just as much as we want flexibility, they know that we have to be accountable. So there's been a lot, but if there's a way to smooth that out, I think that's something that we'd love to work together.
Thank you.
Gentleman's time has expired. Would recognize the gentleman from Massachusetts, Mr. Markey.
Okay, thank you, Mr. Chairman. Governor Patrick, Governor Barber said that he had accepted a deal where his state received 50% of the Medicaid money they receive today, and he could live with that deal.
I'll take his 50% if that's all right.
What would be the impact in Massachusetts if there was a 50% cut in the Medicaid funding that went to the state in terms of the impact on the health care of our residents?
Well, I think that would jeopardize universal care. I mean, that'd be profound for us. Now, we are working very hard, just to repeat myself, to get system costs down, because the cost of care down, because that's important not just for Medicaid but across the economy. And as we gain those savings, that's good for the federal government, just as it's good for those small businesses that are in the private market. But no, that's not. We're not looking for that.
No, Governor Barber.
Governor Barber, if I may, just what I said was we would take 50% of the increase, not that we would cut our total FMAP in half. Just when the increase came, we'd take only half as much. So I'm glad you said that, because I hope others didn't understand what I said that way.
Half the increase.
Thank you for making
Turns
that
out my
clear.
friend didn't want to give up as much of.
I'm not as crazy.
Well, I think that's important for everyone to hear. Mississippi is more than willing to accept that money. But the next question is, Governor Barber spoke about how he felt that the private sector would not insure as many of its employees under this kind of a system. What has the experience in Massachusetts been?
That phenomenon, I understand, is called crowd out. And actually, I'll tell you, when I was looking at this, I've spent most of my life in the private sector. So when I was looking at this, when it was being debated, it seemed to me a business could make a rational decision to stop offering health care for their employees and say, you go on the publicly subsidized. It's actually been the opposite result in Massachusetts. There are more businesses offering employees health insurance today than before our health care reform went into effect.
So it's actually gone up, not down, in terms of the businesses providing health insurance.
Correct.
Now, what about your work with the insurance industry itself to contain cost? How has that proceeded since the bill has been implemented?
Well, I'd say that our work with the insurers has proceeded on a parallel course, not necessarily because of the Affordable Care Act, meaning, we've been seeing, and I meet small businesses, I suspect everybody here does, who are seeing their commercial activity pick up, and then they get that increase in their premium at 20, 30, 50% in some cases. And they can't see a way to add that 1 or 2 employees. And that's important for us because 85% of the businesses in our Commonwealth, as you know, Congressman, are small. So if they don't start hiring, we don't get a recovery. It's as simple as that. And so we engaged with the insurers about a year ago using existing state authority to disapprove excessive rate increases. And we did just that. And then we had a tussle, and everybody eventually got to the table. And what were 20 and 30 and 40% increases last year are single-digit base rate increases this year. But that's a step. It's a temporary step. What we need, more to the point, is that comprehensive payment reform and delivery system reform, which is what we're moving on now, and what is accelerated, frankly, by provisions in the Affordable Care Act.
Now, there are some who say that universal health care harms the economy, leads to higher unemployment, hurts the bond rating of a state. What has been the experience in Massachusetts?
Well, our budgets have been responsible, balanced, and on time for each of the last 4 years, and we're working with the legislature to assure that again this year. Our bond rating started out strong, has remained strong through the recession, and just recently was upgraded from a AA to AA positive outlook. I think we're the only state since 2007 in the country that's had an improved bond rating. And as I said, we've continued to invest in public education at the highest levels in the history of the Commonwealth. So I'll also say our unemployment rate is about 1.5 points below the national unemployment rate. We're not satisfied. We still have to drive that down. But when I talk to those small businesses who are concerned about their premium increases, they appreciate that we have these additional tools now to be able to get at that. And as I said, I meet entrepreneurs who say that the security that comes from universal care in our state is a factor in their decisions to invest in Massachusetts, and we welcome that.
So contrary to public impression, Massachusetts' unemployment rate is down, the bond rating is up, the budget is balanced, and we have 98% of the people with...
And we've got more work to do, but I'm very proud of where we are.
And you've done a great job. Thank you, Governor.
Chair recognizes Mr. Walden for 5 minutes.
Thank you very much, Mr. Chairman. I want to thank the governors for being here today. My home state of Oregon has tried to innovate over the years. I was majority leader of the Oregon legislature when we implemented the Oregon Health Plan. I've been a small employer for 22 years, and we paid for health insurance premium for our workers. And I spent about 5 years on a community nonprofit hospital board. So I've sort of been on every seat at the table on health care reform, trying to figure out how to make it more affordable and available. One of the things I recall from my days on the hospital board was the shift that occurs to the private sector insurance side when the government doesn't reimburse enough. And that especially is true, I believe, on Medicaid, that it is probably the least reimbursement. So you have cost shifting going on from Medicaid and Medicare onto the private sector, which drives up then the insurance costs paid for by those who are trying to provide it, the small employers of America, who, Governor Patrick, you express sympathy for. I'm led to believe, and correct me if I'm wrong, but the Commonwealth Fund has said that Massachusetts has the highest average family premiums in the country. Is that still the case?
I don't believe it is, but I will say that we have trended about a point or so higher than the escalation, even nationally, over a decade or so.
But as you've tried to bring everybody into the pool, your costs have continued to escalate beyond the original projections, right?
No, not beyond the original projections, with due respect, Congressman. But the issue of premium increases is a problem, as I say, all across the Commonwealth and all across the country.
Governor Barber, I know that my senior Senator Ron Wyden and Governor Patrick, your Senator Scott Brown, have teamed up to give states more flexibility if they have their own plans. Now, the President yesterday seemed to embrace that concept, and I'd be curious to hear from all three of you. Does that go far enough? Is it helpful to give you that earlier out at 2014? And if not, what should we be doing?
Of course,
Governor
the devil's in the details. But the things that concerns me, that the things that are in the statute, we are told, the states will still have to do. And Governor Patrick has been talking about, and answer your question, how his costs didn't go up and he didn't have people drop insurance. Well, Massachusetts already had a very, very expansive mandatory standard benefits package. Most states, particularly rural states, don't. And if we get saddled with a standard benefits package like Massachusetts, that's why our employers will drop coverage, because their
Right.
premiums will skyrocket. So if it doesn't give us relief from that and similar things, it's really not much help.
Governor Herbert?
Well, again, as I mentioned earlier, how flexible is flexible? And clearly there's not absolute flexibility. This is not a block grant, do it as you see fit. It is a maintenance of effort still required. The essential benefit package stays the same. The eligibility for Medicaid still is there. So if we get the outcomes that we, the federal government, say to you, state, then you've got flexibility. And that really is not flexibility.
Governor Patrick?
I think from a policy point of view, Congressman, the act is probably, or the bill is probably, we're probably indifferent to it because we, as I said, we're so far down the path, and we have so much flexibility under our existing 1115 waiver, and there's plenty of flexibility in the act.
So then I want to go to another topic. There are some reports out in the last day or two and over time about the waste and fraud, both in Medicare and in Medicaid. Upwards of 10% of the program, the GAO and the IEGs have said, is a result of waste. I met with some physicians in my district, an ambulance operator in another part of the state of Oregon, who talked about some of the fraud and waste they saw occurring in Medicaid, where somebody would feign a problem, call an ambulance, so they could get to the emergency room so they could actually go to a shopping center nearby. And Medicaid gets to pay for it. And I heard that from 3 separate instances. What are you doing, and is the federal government doing enough to get at that? We're talking 20, 30, 40, 50, 60 billion dollars, perhaps annually, in waste and fraud identified by the GAO and others.
One of the things we've done is we try to manage the program. We've reduced our error rate to 3.47%, which is the 4th lowest in the country. Our eligibility error rate is now 0.1%. If just by reducing our error rate as we have, we're saving the people of Mississippi tens of millions of dollars on Medicaid. If you got the national rate down to ours and got the national rate of Medicare down to ours, it would be tens of billions of dollars that the taxpayers would save just by managing the program.
I think I'm out of time, unfortunately. I'd welcome your responses, perhaps in writing afterwards, when my time's expired. Thank you.
Mr. Green.
Thank you, Mr. Chairman. First, I want to mention again, and I know we'll hear it, the health reform is not necessarily Obamacare. This committee spent many years dealing with health care, and it said earlier, whether it be expanding community-based health clinics or the hours we spent over the last 2 years drafting that legislation. The testimony today sounds like the states want the federal government to write them a blank check and allow them to be left their own devices to manage the health care programs without any guidance from the folks here in Washington who have to vote for the money on how the federal tax dollars should be spent. I spent 20 years as a Texas legislator, State House and Senate, and sat on that side for many times and watched what happened. And let me give you some examples of what may not work. In 2003, Texas was experiencing a budget crisis, much like what we see now. At the time, the state decided to drop 175,000 children off the S-chip rolls because they couldn't come up with a state match. State of Texas gets about 65% federal dollars for S-chip enrollment and about 70% federal dollars for Medicaid enrollment. The Texas Medicaid provides coverage at only minimum levels required by federal law for those eligible populations. Texas Medicaid eligibility is granted for 6 months, and recipients must reapply and continue to meet all the eligibility requirements. The problem is every 6 months they have to show up down at our State Department of Human Services. Texas has been trying since 2008 for a Section 115 waiver, but it was even denied in 2008 by President Bush because it wanted to shift Medicaid eligibility individuals into private plans. And I know those private plans are going to have to make a profit to be able to do that. So we'll end up with scarce Medicaid dollars going to profit instead of going to help cover our poorest citizens. We've not recovered from the S-chip disaster in 2003, and Texas still has the highest uninsured rate in the country. And I'm a strong supporter of mandated 12 months continuous eligibility to prevent the states from using children oftentimes as budgetary pawns. Governor Patrick, can you explain the benefits you see in the Medicaid program under health reform?
Well, first of all, Congressman, I agree with almost all the observations you make in terms of how we experience it in Massachusetts, with the one exception of the private insurance. We have our health reform is a hybrid, so we emphasize private insurance, including for Medicaid recipients, and so it's very much a market-based kind of solution, I guess, is what I'm trying to say, which may be why I keep coming back to the point about how across the market, whether for private or public payers, we have to focus on increased costs and what's happening with premiums and what that is doing to our competitiveness. This program has worked very, very well in Massachusetts. The fact that we have over 98% of our residents insured today with reliable health care, and that has been maintained and improved even during a time of enormous economic uncertainty, I think is something I'm very proud of, and I think has been a real help for us in our own recovery. But the broader question of the cost of health care, not the cost of Medicaid, I would do respect, that is a secondary question. The cost of health care, for which in this country we spend 17.6% of what we spend, has got to be addressed. And the Affordable Care Act gives us some tools to do that, and we're trying some others on the state side as well.
Well, let me let the other governors answer, because, like I said, I've been on both sides of the coin, and I watched there were times that we could bring down some Medicaid programs in Texas back in the 80s, and we would get 80% federal funding and only come up with 20%, and yet we still couldn't do it in the state. So Texas does not have a rich Medicaid program by any means. So both Governor Barber and...
First, let me say, I don't mean any offense, but PPACA doesn't come out too good in my accent for the name of this law, PPACA. So I didn't mean any offense by referring to it as Obamacare. It's just easier for me to say.
Oh, I understand. I know it works well on Fox for my Republican colleagues, but it's really an Affordable Health Care Act, and we name things crazy, but it's called health reform. That's the easiest thing
Yes,
ever.
sir.
And I'm glad I don't have any problem with your accent from where I come from.
Well, I figured if there's one guy here to understand, it would be you. I would just say that we are concerned about keeping provider rates sufficiently high that they'll see our Medicaid patients.
Okay.
Mr. Terry.
Thank you, Mr. Chairman. And with my accent, I still call it Obamacare 2. It's easier. My question is for Governor Herbert and Patrick very quickly. The state exchange issue, I think, is an interesting issue, and how states, when you do it yourselves, can be a lot more innovative. Particularly, I want to ask Governor Herbert. You would think that's the traditional pronunciation. Because Nebraska and Utah are similar in population and demographics. Would it be beneficial in a state exchange to have the opportunity to combine with other states and form a regional? And let you go first, and then Governor Patrick.
Yes, I think it would be. I think you'll increase purchasing power and the ability for have more competition, and the consumer will have more options and better options for their own unique needs. Again, without beating a dead horse here, it's not a matter of is my approach better than Governor Patrick's approach. Again, Mitt Romney's a friend of mine. In fact, we looked at the Massachusetts model when we started out. It just didn't work for Utah. It was not in Utah's best interest, so we picked a different pathway. There's probably pros and cons of both of them. It's not a matter of I'm right and he's wrong, or vice versa. But as we work together as states, we can probably find solutions. We talk about it's a little hard to define what is the health care reform message. What is the issue? I don't think the public generally understands. Is it universal access, universal coverage? Is it quality of care? Is it affordability? It's probably all the above. We're tracking it here with the Affordable Health Care Act. probably just in one narrow area of accessibility. I don't know that it helps with the cost control measures.
Well, I appreciate that answer, and Governor Patrick, and then Governor Barber.
I'm really interested in that idea, Congressman. We have about 220,000 people who get their coverage through our connector, our version of the exchange. I think that compares to, about 1,500. Am I right in Utah?
About 1,000.
About 1,000. So it's a slightly different scale because we're trying to because we made different choices. And I agree with my colleague Governor Herbert. I'm not sure that every state in the context of the exchange needs to make the same choices, but I think that flexibility is allowed under the Affordable Care Act. I am very intrigued about how we do more regional pools because, frankly, economically, our people are moving regionally. So, you know, and the idea of having portability of their care, I think, is very responsive to their needs, and that's, I think, what has to be our.
Appreciate that,
Congressman Terry, I just wanted to briefly comment on your question. My state Senate has passed an exchange bill for 3 years running, and the House has not. Both of them have passed a bill this year. We want an exchange. We don't want it. Ours wouldn't be anything like Massachusetts. It would be market, voluntary, and modeled on Utah. So there are. I just wanted you to know that even some of us that don't have exchanges think that they're useful, but not the way the federal act would require it.
All right. Dr. Burgess, may I yield a minute to you?
Thank you, Mr. Terry. Governor Patrick had a question for me, and Mr. Waxman was so rude he wouldn't yield time to you, so I'll be happy to yield Mr. Terry's time to you to ask me the question.
Thank you, Dr. Bridges. I'm good. No, you know, seriously, Mr. Chairman has changed. I am going to, I'm going to have to step away in order to get a plane, and unless you have a question for me, Dr. Burgess, I don't want to.
Well, I was dying to answer your question, and I didn't want to leave the audience unfulfilled with you unable to ask me a question.
Thank you very much. If it's appropriate, Mr. Chairman, if there are other questions after I have to leave that members may have, I would be happy to respond in writing. I just have to make this plain.
The chair thanks the gentleman for.
Well, let me just, in the remaining time I have, one of the issues that we lost out on in this health care reform was the issue of liability reform. I know I have over the years interviewed several doctors from Massachusetts who looked to move to Texas even before we fixed the problem there. How are you dealing with this within your state?
We have. I mentioned earlier that we filed health care reform 2 in Massachusetts, which is the next chapter. It's really around cost control and cost containment. And there is a feature of this which is tort reform. It's not because we have found analytically that defensive medicine is a big contributor to health care costs, but it is a contributor. And so we used a model actually from Michigan, which is not caps. It's an apology and prompt resolution model. It's been piloted at Mass General Hospital in Boston, and they have had fantastic results. So it's a model that works for us, and I'm looking forward to working with our legislators to get it.
The gentleman's time has expired. Chair thanks Governor Patrick
Thank
for
you very much, Mr. Chairman.
coming, and you will respond in writing to any questions in writing.
I'd be happy to, yes. And I hope
Chair,
everyone
thanks.
will please excuse my...
Thanks to the governor, and excuse him. The time now goes to gentlelady from California, Ms. Capps, for 5 minutes.
Thank you, Mr. Chairman. And I had a really good question for you, Governor Deval. I'm sorry that you're leaving, but it's all right. No, I understand. If there's a way you could stay, I would appreciate it. But you've been an excellent testifier.
You try to do it quickly?
Yes, if you can sit back down. I'm not going to make you miss your claim.
Congresswoman, your answer was supposed to be no, Governor. I totally understand that you have to get...
Well, I have other questions to ask your colleagues. First of all, thank you very much for coming. We seem to be using this opportunity to scapegoat Medicaid because the real bottom line is that some people just don't like this health care law. But you have been a success story in reducing the number of uninsured and helping everyone who wants to get access to health care system. My other questions are going to be about children. Your state has the lowest rate of uninsured children in the nation, with over 95% of the state having health insurance. I think that is really an achievement. And I want just to ask you, and you can be quick and then run up. I don't want you to miss your plane. But what is the role that Medicaid has played in this?
Well, it's been enormous. It's the proportion of children insured today is actually 99.8%.
That's stunning. I just want to be on the record. Just say it again.
Well, 99.8% of Massachusetts children have health insurance.
Yeah.
And I am very, very proud of that. Now, Governor Barber made a point, which is true, that children are relatively inexpensive to cover, and it's a very efficient kind of coverage for Medicaid. It's made a big difference for us.
Thank you. You were worried about you catching your plane, and I do appreciate your taking the time. I wanted to ask unanimous consent as I begin or continue my question. Thank you, Governor.
Without objection.
To insert a letter from the March of Dimes for the record, which explains the importance of the Medicaid program for women and children. And I ask unanimous consent if that could be entered.
Without objection. Sorry.
Thank you. Governor Barber, I understand that you have you've said in your remarks that you support the repeal of the Medicaid state responsibility requirements, the maintenance of effort requirements in the Affordable Care Act. When it comes to infant mortality, that means babies dying during childbirth or in the first few months of life. Our nation has a very abysmal record among countries of the world. We rank 46th among all the nations of the world. Now, when it comes to the United States, Mississippi has the highest rate of infant mortality of any state in the United States, 10.7 infant deaths per 1,000 live births. Now, if Congress eliminated the Medicaid maintenance of efforts, you would have the flexibility to reduce Medicaid coverage for pregnant women and infants up to age 1 from the current level of 185% of federal poverty line to 133. Mississippi also has the highest rate of preterm births of any state in the United States. And again, our country doesn't do well on this topic, so I'm not trying to pick on Mississippi, but nearly 19% of live births in Mississippi are preterm. Now, preterm infants are at a much greater risk of health complications, newborn death, and even higher health care costs. I am one who believes that our country's infant mortality rate is a national disgrace. Even during the Bush administration in 2006, HHS fact sheet stated that programs to improve access to prenatal and newborn care could help prevent infant mortality, and it specifically cited Medicaid. So if I could ask you a yes or no question, do you agree with this assessment by the Bush administration that Medicaid can help us address infant mortality?
A little bit.
A little bit, all right.
That's right. I mean, most if I could respond.
Of course.
The biggest problem we have in my state is we have an extremely high rate of illegitimacy. We have a lot of children being born to mothers who are themselves in bad health. Maybe
that's
because
another piece.
Life choices like drugs,
Absolutely.
alcohol, and it is not the health care system that is the principal driver here.
But actually, if these mothers received adequate prenatal care, some of these underlying issues could be addressed, and that's another feature.
And we offer it for
of
free for up to 185%. Yes, ma'am.
But now you'll have the
A lot of them
flexibility.
don't take it.
But that's another issue. But the flexibility to raise it is not going to is going to make it tempting for states to do something that will be in the long run costly. Yes, costly not only in lives, but also to the bottom line of the state's budget.
The majority of all the people on Medicaid in Mississippi are children or pregnant women, and it's up to 185% of poverty. We're not interested in lowering it, but the biggest problem with our sick children at birth, low weight birth, is not the health care system.
The gentlelady's time has expired.
I yield back.
Chair recognizes the gentleman from Pennsylvania, Dr. Murphy, for 5 minutes for questions.
Thank you, Mr. Chairman, and welcome, governors. I'm over here. Good to see you again. I want to go over a couple things about Medicaid expenses in your state. In my state, Pennsylvania, Governor Corbett estimates that about $600,000 will eventually be added on to Medicaid, and it's going to cost state an additional $100 million to $150 million per year. Do you both have estimates in your states of what those numbers might be of an additional Medicaid expense from this bill?
When it's full out, $443 million in year 10.
That's what it'll be in for
1
your
year.
state? 1 year, okay. Sir.
And ours is $2 billion over 10 years. It's a 50% increase in our numbers.
So that's the full cost of Medicaid in both your
Yes.
states, or that's in addition?
That's the increase.
That's the increase out of our general fund.
Now, we also know that the Congressional Budget Office, which admittedly can only deal with the data they're given, they're not allowed to surmise or assume anything, but based upon the data they were given when this bill passed, they estimate about 9 million low-income employees would lose coverage due to some of the exemptions that occur. But Lewin Group now says it could be as high as 85 million. And some questions are that if employers are fined $2,000 per employee for not offering qualified health insurance, that it might actually serve as an incentive to expand those numbers up to that upper level of 85 million or so. So are your numbers that your states have based upon some of these higher or lower numbers? I'm just curious in terms of the actual population that you think might pick up. How confident are you on the accuracy of those numbers, and might it even be higher?
Well, I don't know the numbers that you've given there, but our estimates are based on the fact that we're going to have to increase eligibility up to 133% of poverty. We're not covering that much in Utah.
I see.
And the essential benefit package would have to be changed and modified and enriched. And so we're going to have to give more, and so that's going to add to the cost.
And my question is what happens if anybody has looked in your states, if more employers drop their coverage and put people on Medicaid?
Well, if more employers drop their coverage, then clearly the eligibility will entice people to use Medicaid as the insurer. And so our numbers will go up. I don't know what the percentage of that would be.
Governor Barber, you would estimate
I'm
as well.
concerned that we underestimate the actual increase in costs. But as I said earlier, we have a lot of small businesses that offer insurance to their employees right now that won't meet what we fear the standard benefits package will be. Mm-hmm. And for a lot of people, they'll just pay the $2,000.
Well, let me ask you then in another area, because some of the talk has been and I know, Governor Barber, in your testimony, in your written testimony, too, you talked about the delays in getting waivers taken care of, the delays in responses that are interminable. And you mentioned some things about the medical school, and you also talked about physical exams requirement is not there. If this money came to the states in the form of a block grant and said, if you could design Medicaid the way you would want to do it, granted, it was designed in 1965, and that was back in the era when a hospital that had an x-ray machine on wheels was considered pretty modern. But if you could redesign it, would your states want that authority? Do you think you could modernize things and deliver better health care quality to more people at a lower cost? Do you think you could?
We think we'd have a better fit for our state. We could move more toward an insurance kind of model. But, we don't think it would just be better quality care. We could save you money. As I said at the beginning, we would take a 50% reduction in the annual increase, and that's a lot of money over time in savings for the American taxpayers. If we could cut the rate of Medicaid spending going up in half, and we'd be willing to have a block grant and us take that risk. Mm-hmm. If we weren't able to cut the rate of increase by half, come out of our pockets.
Well, let me ask specifically then, in terms of one of the things you mentioned, Governor Barber, in your testimony about requiring Medicaid patients to have an annual medical exam. What benefits would you feel that would have in terms of improving quality?
Well, for so many people, they would just have a better understanding, particularly older people have a better understanding of what their health risks were and are. Mm-hmm. They would learn more. We try to give them a briefing about their medicines, but they could get much farther along on that. But for a lot of them, they would find out things they don't know. If you go to the emergency room for your care, that's the worst place for primary care. It isn't just expensive. It's not designed for primary care. Mm-hmm. So it would help these people have a lot of people have a better quality of life.
Okay. Governor, what about in your state? What about Utah?
Well, again, I think we can do it better. I would advocate for states to be able to be the innovators and creators of success. It boils down to me, just a simple principle. Do you trust the states? Do you trust the governors to do this? And some of you do, and some of you don't. Some of you are a little John-eyed about turning the reins over to the states. And I think we've proven the ability to, in fact, provide good service. We balance our budgets. We are out there growing the economy. We're doing things that we need to be doing in our respective states with our respective different demographics. I have a young state. Our median age is only 28.8 years of age. I have a whole different demographic to deal with on health care than other states that may have a more aging population. So that's why I think let states and governors deal with it. I think that would find success that we otherwise would not have.
The gentleman's time has expired. And Chair recognizes the gentleman from Pennsylvania, Mr. Doyle, for 5 minutes.
Thank you, Mr. Chairman. It was interesting to hear from Governor Patrick about the economic impact of health care coverage in Massachusetts. It seemed to me that while we all know that providing our most vulnerable Americans access to health care will save individual families from extreme economic hardship due to medical costs, there's apparently also a larger economic role that health care coverage plays. Looking at the Massachusetts model, after they rolled out their extensive plan, the number of insured shrank to an impressive 2.7% statewide, and uncompensated care costs went down by 38%. That hardly seems like a failed health care program to me. In 2009, nationwide, uncompensated care costs were $40 billion. If Massachusetts is an example of the nationwide effect, we are talking about a potential savings of $15 billion as we lower the rate of uninsured in the country. Similarly, it seems to me that cutting back on Medicaid and leaving more people without any type of insurance is short-sighted at best and more likely flat-out dangerous. As we all know, $1 cut from Medicaid means $2.33 cut from the state's economy. You know, it's discouraging to me that the majority continues to spend time arguing over taking away health care from our most vulnerable, when what we really need to focus on is creating jobs and incentivizing economic growth. In my state of Pennsylvania, where the uninsured rates are nearly 20%, we could save hundreds of millions of dollars adopting the Massachusetts model. Hardly, in my opinion, a failed health care model. Mr. Chairman, I want to yield the balance of my time to Mr. Wiener for questions.
I thank the gentleman, Mr. Barber. Perhaps you and I should both have those white things I have at the UN so we can understand. You can understand my Brooklyn accent, and I can understand yours.
We need an interpreter.
But I just want to ask you a couple of questions. I didn't hear you respond, governors respond about these questions about tort reform. You don't want federal tort law to supplant and supersede state tort law, certainly. Right?
I thought the question was what happened when we did this in our state,
well,
and it's been very, very, very beneficial.
Would you agree, I assume you would, that you want state law to supersede federal law? You don't believe there should be a federal tort law, do you?
I think in federal cases, I think there ought to be a federal tort if it's about federal law. Now,
Mr. Barber, as you know, there's no such thing as a federal tort right now.
Well, if you go into federal court in Mississippi and a case arises in a state law prevails. So we wouldn't want to change that.
I can take back my left hand. Medical malpractice is a state law. Are you aware of that?
That's correct.
Okay, so you don't want federal law to supersede state medical malpractice tort law?
Not in state cases.
Yeah, I didn't think you did. Can I ask you this question? From the conversation we're having here, you think you have any additional costs at all before 2017? Are you both aware that you don't? You have no additional costs before the year 2017?
That's why I said, sir, when I was trying to say what the costs were, they're so backloaded.
Right. Let me ask you this question. Do you anticipate in the future Mississippi will have more or fewer poor people with you as governor?
Depends on the national economy. As long as we've got the economy we got now, we're going to have more. We're going to have more.
No, I understand. But is it your policy, Governor, to reduce the number of poor people in your state?
The policy of our state is to grow the economy and have more people working.
Is that a yes, sir?
That should be the result. Should be the result.
It's more or less a rhetorical question. Of course, you endeavor to have fewer poor people. That would make you a more successful governor, maybe even a candidate for higher office. If you have fewer poor people, wouldn't your Medicaid costs go down?
Well, when we added 60,000 employees my first 3 years as governor, yes, sir, people went off the rolls. Our Medicaid costs were better under control.
So if after 2017 you have fewer poor people than today, your Medicaid costs will go down, won't they?
Well, no, they'll actually go up because we're
Okay.
going to put all of these people on Medicaid under the Affordable Care Act.
All right, I'll put it this
that
way.
are not on it now.
Well, let me put it out in terms of the law. Under the Affordable Care Act, people eligible will have a family of 4 making $30,000 a year will be the maximum coverage under the increase under the Affordable Care Act. Starting in 2017, when the federal government stops absorbing 100% and absorbs 95% of that, if your number of poor people goes down a sufficient amount, if you're a good governor and your number of poor people goes down, your Medicaid costs will go down, won't they?
But the definition of poor and eligible for Medicaid are two different
No, I just
things.
gave you the definition,
The number
sir.
of people eligible for Medicaid will go up.
30,000 for a family of 4 will be the new limit. If it goes down and you do a good job as governor, fewer poor people, lower Medicaid costs for the
gentleman's
state.
time.
I would endeavor that you should
Gentleman's
perhaps
time has
pursue that
expired.
policy.
Not compared to today, Congressman.
Well, that's exactly the number I gave you is the new limit.
The gentleman's time has expired. Chair recognizes the gentleman from Texas, Dr. Burgess, for 5 minutes for questions.
And I thank the chairman for the recognition. Let me just, of course, Governor Barber, and thank you both for being here. I just wanted to clear up. You're concerned about what we call this law, and I was too. In fact, I spent a long night before the Rules Committee trying to get the word affordable struck from the title on a germaneness issue because I couldn't see how affordable was germane to the bill in front of the Congress, but I wasn't allowed to proceed with that. So we're stuck with it, with what it's called. Governor Herbert, you referenced the need to expedite the Supreme Court review of the constitutional challenge to this law that was passed just less than a year ago. Now, when Judge Vincent in Florida issued his opinion just a few weeks ago, he said that injunctive relief was not necessary, that his declaratory judgment was all that was required because officers of the federal government would comply with the wishes of the court. Now, was he not correct in that statement?
Well, he may be, he may not be. That's still yet to be determined. The process is not completed yet. I know some states are taking the position that he is, in fact, accurate in injunctive relief. Others are saying it's not. And so, for me as a state, speaking for Utah, it's kind of like we're sitting on some shifting sands. We don't really know.
Because under normal circumstances, it would be likely June of 2012 before that Supreme Court ruling would occur. If I am to understand things correctly, officers of the federal government are not complying with the spirit of the law in that implementation of the law is still proceeding at a fairly rapid rate. So this thing will be down the road another 18 months. And then if it's struck down, you will be asked to unwind under a court order, unwind all of the things that have occurred under the Affordable Care Act, and it will be difficult to dissect out what you were doing with the state exchanges before the law went into effect, and now what has been struck down by the Supreme Court. Is that correct?
That would be correct. Again, the uncertainty is really a problem for us to know which way to go and what to do.
There are, and I really do thank both of you for being here, and there's so many things that could come up. Just one, in your written testimony, Governor Herbert, you talked about you wanted to get to a point where you pay for value. Now, are you aware that Donald Berwick, the head of Center for Medicare and Medicaid Services, has testified that he too wants to go to a system that he pays for value? Have you two communicated on this point? Because he is the federal head of the Medicaid program.
He and I haven't. There may be some communication with our staff and our Medicaid people, but he's not talked to me.
It seems to me that there is the common ground. Now, you also talked in written testimony about what the accountable care model, the ACO model may be for Utah. And I don't disagree with that. The rules, unfortunately, that were due last September on accountable care organizations are still pending. So it's kind of like the dog ate my homework over at HHS. We haven't got that to you yet. How are you able to proceed with this without the certainty of what the federal rules will be?
Well, it's very difficult. In fact, as mentioned earlier about the high-risk pool, and we had to wait about 6 weeks trying to get questions answered on high-risk pool and whether we should implement. We already have one in the state. Part of the Affordable Care Act requires a federal high-risk pool. But the answer came back, we can't answer the questions. We haven't had a chance to read the bill.
Yeah,
and to
that's
understand
something.
the impact.
Governor Barber, you had some interesting comments about the high-risk pool at the National Governors Association on Sunday. Could I get you to quickly summarize those about the number of people that you were covering and the number that are covered
makes
now?
Governor Herbert's point about the need for a quick decision by the Supreme Court, because we were required to create a second high-risk pool in Mississippi to comply with this law. Even though we had had one since the mid-90s, it insured 3,600 people. And we were forced to add another one, and now in the course of however long it's been in effect, 58 people have signed up, when if they could have just taken our high-risk pool and not forced us to have another one.
Yeah, the simplicity could be absolutely stunning in that, and actually Nathan Deal and I last year had legislation to try to do that, but it didn't fly, unfortunately, with the Affordable Care Act. Let me just point out Representative Wiener's comments about the state sovereignty on medical liability. There is, of course, a federal program called Medicare, and Medicare is equally administered across all of the states without regard to state sovereignty. Would it be possible to set up a medical liability system within Medicare, within that federal program, say perhaps patterned after the Federal Tort Claims Act that is in effect for the federally qualified health centers, that could provide some relief to your practitioners on medical liability costs?
Yes.
I think so. It's an interesting idea, and I'm not an attorney. I don't play one on TV, so I don't know if I can comment on that.
The gentleman's time has expired. The chair recognizes a gentleman from Washington, Mr. Inslee, for 5 minutes for question. I'm sorry. Okay. All right. We had Mr. Schakowsky for 5 minutes.
Thank you, Mr. Chairman. The Illinois Governor Quinn has sent a statement from Illinois that outlines the many benefits of the Affordable Care Act. Among other things, he points out that the Medicaid expansion will cover 700,000 new adults who will have health insurance coverage, many for the first time in their adult lives. He adds the Affordable Care Act is helping to make comprehensive health insurance affordable and accessible to all Americans, while providing the flexibility to allow governors to implement innovative policies that benefit the citizens of each unique state. In Illinois, we do not see the Affordable Care Act as an alternative or distraction to the urgent need for jobs and economic growth. We see the law as a vital part of our economic recovery. Mr. Chairman, I ask unanimous consent that Governor Quinn's full statement be included in the hearing record.
Without objection, so ordered.
Thank you. Governor Barber, you have talked about the reason that infant mortality rates, et cetera, are up in Mississippi, and also you were talking about in terms of Medicaid, we have people pull up at the pharmacy window in a BMW and say they can't afford their co-payment. Well, first of all, let me say that the federal government has made fraud in Medicare and Medicaid a top priority and has, for the first time, really put resources into doing that. But would you say that Mississippi uniquely, because other states, it's really provider fraud that is the bulk of the fraud that goes on in Medicare and Medicaid, asking for reimbursements of care that really wasn't given or prescription drugs. Would you say in your state it's your people who are defrauding the big problem in fraud?
Congresswoman, and my understanding is that that's not considered fraud, that in the federal rules, if a person says they can't afford to pay the copayment, the provider can't challenge it. And of course, the sad thing about that for us is the state doesn't save any money. It's the provider who gets shorted. But I report that because providers report it to me. It is not my understanding that that is, quote, fraud under the federal law. We have really done a good job of tamping down on our error rate, including fraud.
So it's really people trying to treat this, you know, it's not about, it's about poor people or not so poor people trying to cheat the system that's been the big problem?
We certainly had a problem at one time of people who were not eligible being on the program, and it was the state's fault because the state was not following the rules. But do we have provider fraud? Yes, ma'am, we do. And we also have waste from providers as well.
Which all of us, I think, agree we have to go after. You know, in Illinois, we get a 50% match of federal dollars in our Medicaid program. Mississippi gets almost 75% match. Utah gets about 71% match. In Illinois, as a matter of fact, on federal for federal spending, Mississippi gets $2.02 back for every dollar in federal taxes it pays. Utah gets about $1.07. Illinois gets about 75 cents back. So we don't do as well as you do. But do you not think that the fact that 75% of the dollars, for example, Governor, comes from the federal government, that maybe the federal government has some right to set some parameters, or no?
Sure, the federal government should have some right to set some parameters. I think the federal government overruns the program by far. I don't think that's unique to Mississippi. We get 75 cents because we're the poorest state in the country. We would love to trade with Illinois and be a much richer state and get a smaller percentage. But for us, the beauty is y'all would save a lot of money if you'd let us manage the program and reduce our costs. You'd get $3 out of 4 of the savings.
Well, actually, I wanted to mention that with Governor Herbert. You were talking about your support for federalism and the pitch to let Utah be Utah. But actually, Medicaid already gives you a great deal of flexibility in designing your program. You can design your delivery system. You can set payment limits. You can do cost-sharing limits and benefits. And even prescription drugs are optional. So what are you saying? Just completely hands off? The federal government should not have a right to set some sort of limits?
Well, clearly you have a right, and I respect that right. It's a matter of, is there a better way? I think we ought to be more co-equal partners in discussions of what the process is. I stipulate that the intention and objectives of Medicaid and the Health Care Reform Act are designed to help the people. We all want that same goal. What we differ about is process.
And yet both of you say you'd rather see it repealed, right?
The PPACA? Yes, ma'am.
I believe that parts of it are unconstitutional. I don't think we want to have an unconstitutional law in the books.
The gentlelady's time has expired. Our time is limited. The governor's time is limited. We want to thank the governors for their testimony. This has been an excellent panel. Before we adjourn, we have a couple of housekeeping items. Chair recognizes the ranking member, Mr. Waxman, for unanimous consent request.
Mr. Chairman, we've had letters from many different groups in supporting maintaining Medicaid eligibility. We have a statement from the SEIU opposing repeal of the maintenance of effort and requirements in the ACA for Medicaid. I'd like to have that as part of the record.
Without objection. It's ordered.
And I did want to take a second or two to talk about the Medicaid citizen documentation. I think the statement by Mr. Borton was incorrect. States have two ways to establish whether someone's an actual citizen. One could be submit a name, Social Security number, date of birth, then go to the Social Security Administration for verification. And if the Social Security records match, the individual meets the documentation requirements. As of February, 33 states, including Mississippi and Michigan, have elected this option. In the alternative, a state can require that individual provide either a U.S. passport or a birth certificate and a driver's license or other photo ID. In no case may an individual self-declare citizenship or legal immigration status. Thank you, Mr. Chairman.
Without objection, so ordered. The gentleman, Mr. Bass, would like to insert for the record a study on how to reduce Medicaid drug prices. And Mr. Griffith from Virginia has a letter from the governor of Virginia to insert in the record. Without objection.
Mr. Chairman. Mr. Chairman.
Insert in the record.
Mr. Chairman.
Dr. Gingrich.
I have a letter also from our former colleague, Governor Nathan Deal of the state of Georgia, who has some very interesting comments in his letter. I'd like to submit it for the record.
Without objection, That'll be inserted in the record. Members will have 10 legislative days to submit questions for the record. I ask that the witnesses please respond promptly to these questions. Without objection, so ordered. The hearing is now adjourned.
Thank you.
We got there too.
Many meetings with Secretary Levitt right after Katrina. Very helpful us.
Yes. Well, we appreciate the opportunity to help out.
Like, yeah. I found snow in Seattle.
No, I didn't mean to turn my back on Congressman Anderson.
Yeah, I would like to do that. Thanks for speaking.
bank at El Paso. Let's see. We'll say this is the inside of the bank. Nino is the safe.
Which weighs 3 tons and can't be opened with dynamite.
There's the part with 2 cashiers. This is the manager's desk. Right in back is a fancy cabinet containing bottles for offering drinks to the rich depositors. There's the main door, and opposite a billet double wall. What happens, Groggy? Let's say you've already killed the 2 cashiers and the manager. And for the next few minutes, you're the boss of the bank. Now what?
The time's been wasted, Indio.
Right, a waste of time. Especially, Groggy, to blast open that damn iron safe, we'd have to be using so much dynamite that the whole bank would just disappear. And you'd all go up with it. And besides, the presence of a safe alone doesn't always signify that there is money inside. To help you understand what I mean, I would like to relate a nice little parable. Once upon a time, there was a carpenter. You don't think a carpenter can make money, eh? No, you're wrong. This one did well, because he was a builder of safes. There was a banker once who decided he must have his iron safe disguised to look like a wood cabinet. To get it made, the banker goes to our carpenter for the job, and one day, as destiny has it, the carpenter's in El Paso. He happens to walk into the bank there, and what does he find? The cabinet. Since he'd worked on the cabinet, he spotted it right away. From that day on, he couldn't work anymore.